So in today's video we are going to deal about inguinal canal, a schematic representation of where it is present and how it is oriented. So in abdomen region, inguinal canal is a very important part. So this inguinal canal, it is nothing but an musculo-aponeurotic tunnel. So it is a musculo-aponeurotic tunnel. That means it have both muscular part and an aponeurotic part, and it is going to give a canal-like area, and that is called as tunnel. So muscular and aponeurotic tunnel is nothing but inguinal canal, and it is about 4 cm in its length, and extent it is extending from a deep inguinal ring. So we have got a ring called deep inguinal ring, and then we have got a ring called superficial inguinal ring. So this superficial inguinal ring, it will be triangular in shape. Deep inguinal ring, it will be oval in shape. So this is deep inguinal ring, and this is superficial inguinal ring. So connecting these two rings, this is considered as opening of the inguinal canal, and connecting these two rings we have got the inguinal canal placed. So this is the whole of the inguinal canal, which is connecting the deep inguinal ring and superficial inguinal ring, and this is a tunnel shaped area. This inguinal canal is actually present. We have got inguinal ligament. I think you know what it is. So this inguinal ligament which will be present below this. So below this we have got the ligament called inguinal ligament. So which is extending from anterior superior iliac spine to pubic tubercle. So the medial half of the inguinal ligament. So the medial aspect of the inguinal ligament is related to the inguinal canal which is present just above it. So this is the inguinal ligament. So this is the inguinal ligament we have got. In the medial part, upper part, we have got relation of this inguinal canal placed. So now we are going to see about the contents of this inguinal canal. So talking about the contents, we have got two important contents placed. So we have got contents. So basic things we are seeing now in this thing. First, about the introduction, musculo-aponeurotic channel and where it is placed just above the inguinal ligament medial part. Talking about the contents, we have got two important contents. That is, we have got first spermatic cord. So we have got spermatic cord which is seen in males, and in females it is replaced by round ligament. So round ligament is the structure which is seen in females. So in males it is spermatic cord, in females it is round ligament. And one more content which is present here is a nerve called ilioinguinal nerve. The nerve is called ilioinguinal nerve, and among this is the two contents placed, and this is seen in both males and females. And now this spermatic cord or round ligament, it is seen as an entire content which is starting from the deep inguinal ring to superficial inguinal ring. In the whole of the canal it will be passing. If you are taking ilioinguinal nerve, it is seen as a partial content. It is piercing the inguinal canal in the middle part, and then it is seen in the medial aspect alone. So it is considered as partial content. So these are the major two contents of the inguinal canal. And now we are going to see about the boundaries in detail. So we are going to deal about the boundaries of inguinal canal in detail. So we have got boundaries like two walls. We have got walls, and we have got roof and floor. Along with that we have got inlet, nothing but deep inguinal ring, and outlet, that is nothing but superficial inguinal ring. And the walls which we have is anterior and posterior. Anterior and posterior wall. So these are the walls we have, and these are the, so first, second, roof, floor, inlet and outlet. So these all the boundaries which are seen in the inguinal canal. Roof, floor, anterior wall, and behind that posterior wall, this is the inlet and this is the outlet. About these things we are going to deal in this video. So we are going to see a schematic representation of how it is bounded in all these ways. So first we are moving on to anterior wall. So first thing what we are going to see is about the anterior wall. So we are going to see about anterior wall of inguinal canal. So talking about anterior wall, we have got our inguinal canal. So we have got our inguinal canal placed, and this is directed forwards and medially, and this is the deep inguinal ring, and this is the superficial inguinal ring. So now we are going to see about the, from above we are seeing, so we are having this as the anterior aspect. Consider this as anterior aspect, and behind we will be having posterior aspect. So now we are going to deal about anterior wall alone. So about this only we are going to deal in detail. So in anterior wall of the, that is in this anterior aspect of the inguinal canal, what are the structures present we are going to see. So for this we are dividing into medial and lateral aspect. So just imaginarily you divide this into medial and lateral aspect. In the medial aspect anterior wall, it is mainly contributed by, first thing is skin. So we have got skin as the first layer of the anterior wall, and just behind the skin, as we know, we have got superficial fascia present. So we will be having a facial layer which is present just below the skin area, and that layer is called as superficial fascia. So first layer what we have in the anterior wall is skin, and then we have got superficial fascia, and then we have got aponeurosis of external oblique abdominis muscle. So the next thing what we have is aponeurosis of, so we will be having external oblique abdominis muscle as the muscle of abdomen. So that is going to form aponeurosis in the anterior medial aspect. So that aponeurotic part is going to form anterior contribution. So in the medial aspect, anterior wall is contributed by skin, superficial fascia, and the aponeurosis of external oblique abdominis. External oblique abdominis. So these are the three structures which are related in the anterior medial aspect. And talking about the posterior aspect, lateral aspect, we have got skin and superficial fascia extending. So skin and superficial fascia is common for medial and lateral aspect. But in the lateral aspect, instead of aponeurosis of external oblique, we have got muscular fibers of internal oblique abdominis. So here we will be having muscle part of internal oblique abdominis. So this is the difference between medial and lateral aspect. So we are dividing this into medial and lateral aspect. Anterior wall we are seeing, in the anterior aspect, first layer what we have is skin, then we have got superficial fascia. So this whole thing is skin. So this is the skin area, and then we have got superficial fascia present behind that, and in the medial aspect we have got aponeurosis of external oblique abdominis. In the lateral aspect we have got muscular fibers of internal oblique abdominis muscle. Internal oblique abdominis muscle. So this is how we have got anterior wall of inguinal canal related. So this is the structures which are related in the or forming the anterior wall. We are talking about anterior wall here. Anterior wall contributed by skin, superficial fascia, and aponeurosis of external oblique abdominis in the medial aspect, muscular fibers of internal oblique abdominis in the lateral aspect, and the canal which you are seeing is inguinal canal. So inguinal canal. Now we will move on to posterior wall. So here only I will be showing you. So next what we are going to see is posterior wall. So we are going to deal about posterior wall now. So about posterior wall, again we have got our inguinal canal. We have got deep inguinal ring and superficial inguinal ring, and behind that on the whole aspect we have got fascia transversalis related. So on the whole aspect, in the posterior aspect, so we are talking about anterior and posterior, and here we have got posterior part, and here we have got anterior part. Anterior we have dealt already. Now we are talking about the posterior wall of the inguinal canal. In the posterior aspect, all the part, the whole of the inguinal canal is covered by fascia transversalis, and then the medial, in between the fascia transversalis and the inguinal canal, in between area we have got a part called conjoint tendon. That is medial part, medial half of the inguinal canal is related to conjoint tendon. So we have got conjoint tendon which is related just in front of fascia transversalis. Conjoint tendon is formed by fibers of internal oblique abdominis and transverse abdominis muscle. So this is conjoint tendon. So conjoint tendon is present just behind the fascia transversalis. This is seen in the medial half, related to the medial half of posterior wall of the inguinal canal. Just in front of that, we have got the floor formed by inguinal ligament. So from the floor of inguinal ligament, we have got some fibers extending to the posterior aspect. So to the posterior aspect, medial 1/4 area, we have got a ligament extending, and that part is called as reflected part of inguinal ligament. So some ligamentous fibers will be extending towards the posterior wall from the inguinal ligament, which is seen in the floor of the inguinal canal, and that is going to be related to medial 1/4. So this is medial 1/4, this is medial half, and the whole is related to fascia transversalis. So this is reflected part of inguinal ligament. So this is reflected part of inguinal ligament. This is how anterior and posterior wall is related to inguinal canal. So we are dealing about the boundaries of inguinal canal. Anterior wall we have seen, which is related to skin, superficial fascia, external oblique aponeurosis and internal oblique muscle. Talking about posterior wall, on the whole extent we have got fascia transversalis, in the medial half related to conjoint tendon, and medial 1/4 part related to reflected part of inguinal ligament. Now we will move on to the other boundaries, such as we have got again roof and floor. So we are going to see about roof first. So we are going to deal about roof of the inguinal canal. Roof of inguinal canal. Going to deal with roof of the inguinal canal. So here we have got our inguinal canal placed with again deep inguinal ring, superficial inguinal ring, and here we have got from the anterior aspect our internal oblique abdominis muscle coming. So our internal oblique muscle, it is coming and going to form an arch above the inguinal canal. So it is going to form an arch. From the anterior wall, it is passing above the inguinal canal and going to the posterior aspect. So it is, that is what conjoint tendon what we have in the posterior wall. So this is how it is going to pass. This is fibers of internal oblique abdominis muscle. So fibers of internal oblique abdominis muscle, it is going in this way. And then we have got from the lateral aspect, we have got our transverse abdominis coming. So we have got our transverse abdominis again going to join with the internal oblique above the inguinal canal. So we have got the fibers of internal oblique abdominis and transverse abdominis. So these are the two muscle fibers which are going to arch above the inguinal canal to join the posterior aspect as conjoint tendon. So this aspect is called as conjoint tendon, which we seen in the posterior wall. So this is how it is going to join, first arching above, that is going to form the roof. So roof is formed by both these things, that is transverse abdominis and the internal oblique abdominis muscle. So this is how we have got roof of the inguinal canal placed. So roof is covered by these two muscle fibers. Now we are going to move on to the floor aspect. So we are going to deal about floor of the inguinal canal. So we are going to see about the floor. Talking about the floor, as I said before, we have got in the first aspect only, starting of this class only, I have intimated, we have got the inguinal canal. Just below the inguinal canal, we have got a ligament. So we have got our inguinal ligament placed. So medial aspect of the inguinal ligament is related above to the inguinal canal. So this is the inguinal canal which we are dealing, and this is the inguinal ligament. So this one is the inguinal ligament we have. So floor is formed by this inguinal ligament, and then from the inguinal ligament we have got some fibers extending to the, so we have got some more fibers which are extending towards the floor from the again inguinal ligament, and those fibers which are triangular in shape, and those fibers are called as lacunar ligament. Lacunar ligament. So the floor is contributed by inguinal ligament and also by lacunar ligament. The inguinal ligament is nothing but the ligament which is extending from pubic tubercle, from the pubic tubercle to the anterior superior iliac spine. Anterior superior iliac spine to the pubic tubercle, we have got the attachment of inguinal ligament, and so floor is contributed by inguinal ligament and the lacunar ligament, and roof is contributed by internal oblique abdominis and transverse abdominis muscle. So this is how we have got the other two boundaries of roof and floor placed. Now we will move on to the next two, that is inlet and outlet of the inguinal canal. So now we are going to see about the inlet and outlet. So first thing, inlet. Inlet of inguinal canal. So inlet of inguinal canal we are going to see. As I said before, we have got inlet is nothing but deep inguinal ring. So deep inguinal ring is otherwise known as inlet of the inguinal canal, and this deep inguinal ring is present in the fascia transversalis, that is in the posterior wall. So in the posterior wall of the inguinal canal only we have got this opening called deep inguinal ring. So fascia transversalis, we have got this oval opening placed. So shape is oval. Shape is oval. Now we are going to see this where it is placed. So we know already we have got our pubic symphysis with pubic tubercle, and then we have got our anterior superior iliac spine, pubic tubercle. From that we have got a ligament extending, and that ligament is nothing but inguinal ligament, and just above this we have got this point as midpoint of inguinal ligament between the pubic tubercle and anterior superior iliac spine. Between the pubic symphysis, that is this point, to the anterior superior iliac spine, we have got another midpoint. So we are going to place a midpoint between the pubic symphysis and anterior superior iliac spine. We are calling that as mid-inguinal point. So mid-inguinal point is a point between pubic symphysis and anterior superior iliac spine. In that point only we have got this deep inguinal ring placed. So which is oval in shape. So deep inguinal ring is placed between the pubic symphysis and anterior superior iliac spine, which we will call as mid-inguinal point. It will be around 1.25 centimeter above it. So this is the point we have got our deep inguinal ring. This deep inguinal ring is again bounded by some structures which we are going to see. So this deep inguinal ring, it is placed in the fascia transversalis, and it is bounded above medial and lateral aspect. Above it is bounded by the muscle fibers of transverse abdominis. We have seen transverse abdominis, it is coming from the lateral aspect. So those fibers are going to bound the above upper aspect of the deep inguinal ring. And then in the lateral aspect we have got internal oblique abdominis muscle. So we have got the internal oblique which is coming from the lateral aspect, which is going to bound over here. So we have got internal oblique abdominis present in the lateral aspect. In the medial aspect we have got an artery placed, and that artery is nothing but inferior epigastric artery. So these are the three boundaries seen in the deep inguinal ring. Deep inguinal ring is bounded above by transverse abdominis muscle, and laterally it is bounded by, again we have got internal oblique muscle, and in the medial aspect it is bounded by inferior epigastric artery. So these are the structures which are bounding the deep inguinal ring. We are talking about deep inguinal ring and their boundaries. It is oval in shape, present 1.25 cm above the mid-inguinal point, bounded above by transverse abdominis, laterally by internal oblique, medially by inferior epigastric. So this is medial, this is above, and this is lateral. So this is how it is bounded. Now we are going to see about the outlet. So above the outlet we are going to deal now. So we are going to deal about the outlet of inguinal canal. So this outlet is called as superficial inguinal ring. It's called as superficial inguinal ring. And this is present in the aponeurosis of external oblique, that is in the anterior wall. The posterior, that inlet deep inguinal ring is seen in the facial transversalis, that is in the posterior aspect. The outlet superficial inguinal ring is seen in the anterior aspect, that is in the aponeurosis of external oblique muscle. So aponeurosis of external oblique muscle, where we have got this outlet placed, and this outlet is about triangular in shape. So we are going to see the placement of this. For that again we have got our pubic symphysis, pubic tubercle, and this part is pubic crust, and then we have got our inguinal ligament placed here. Inguinal ligament is placed. Now for superficial inguinal ring we have got our boundaries as our superficial inguinal ring is triangular in shape and it is present just above the pubic crust. So just above the pubic crust we have got base of the superficial inguinal ring, and then it has triangular in shape. So it is seen in such a way. So this is the superficial inguinal ring we have got, which is triangular in shape, and here it is bounded below, that is base, it is bounded by pubic crust. So this is pubic symphysis, and this is the pubic crust, and this is pubic tubercle. So this is how we have got. And now we are talking about superficial inguinal ring, which is triangular, have got base below and apex above, and then we have got two cruras medially and laterally. So this is medial crura and this is lateral crura. So now we are going to deal about the things which are going to form this boundaries. So base we already have seen. Base of the superficial inguinal ring is formed by pubic crust. So this is the first boundary. Base is formed by pubic crust. And then we have got apex. Apex is joined by two cruras. So we have got cruras which is seen on the either side. So superior crust and inferior crust we will call. So we have got here some crura, that is we have got some fibers which are extending like this, which is going to join together and form this superficial inguinal ring. So base is formed by pubic crust, and the apex, this is the apex part, Apex is contributed by superior crus and the inferior crus of the superficial inguinal ring. This superior crus is contributed by again fibers of external oblique aponeurosis. So the two cruras are formed by aponeurosis of external oblique. This is called as superior crus and this is inferior crus. So this is the two crus we have got for the superficial inguinal ring. Superior and inferior crus which are going to form by superficial inguinal external oblique abdominis aponeurosis. So external oblique oblique muscles aponeurosis is the place we have got the opening placed, and here we have got two crura, superior crura and inferior crura contributed by this aponeurosis. Apex is contributed by approximation of these two crura and base is contributed by pubic crest. So this is apex, superior crura and inferior crura which are formed by external oblique aponeurosis. So this is how we have got inlet and outlet placed. Superficial inguinal ring and deep inguinal ring. How it is bounded we have seen in this topic. And these are about the schematic representation of inguinal canal we have in our body. And if any, because of the opening and the weakness of this area, if any contents are coming out of the inguinal canal, through the inguinal canal, it will come out as a sac, taking the peritoneal covering also. So that condition we will call as inguinal hernia. Hernia is a condition where the abdominal contents will come out through the opening or some weaker places. If it is coming through inguinal canal, we will call that as inguinal hernia. And all these boundaries are used for approximating the whole of the walls in proper position. To keep the inguinal canal and its content in proper position, all these walls are giving its contribution. It have got again slit valve mechanism, shutter valve mechanism, flap valve mechanism and all. So these are the things which are going to contribute for the proper positioning of inguinal canal during intra-abdominal pressure.
About inguinal canal we are going to read. So this is inguinal region. You know we have an inguinal ligament which is connecting the pubic symphysis with the anterior superior iliac spine. This white color demarcating line between the abdomen and the thigh region, we are calling this ligament as inguinal ligament. So above this inguinal ligament we have a tubular passage. So we are calling this as inguinal canal. Okay. So this is inguinal canal which is present above the inguinal ligament and it is going to occupy only the medial half of inguinal ligament. So this whole extent we will call as inguinal ligament. In that only the medial half of the part is occupied above by inguinal canal. This inguinal canal, it is actually a musculo-aponeurotic canal. So what does it mean is, it will be having both muscle fibers and aponeurotic fibers for the formation of this canal. It is contributed by equal amount of muscle fibers and also aponeurotic fibers of the abdominal muscles. As we already read, we will be having external oblique, internal oblique and transverse abdominis. Those muscle fibers along with aponeurotic fibers going to contribute for the formation of inguinal canal. And as you know, it lies above the medial half of inguinal ligament. This is inguinal ligament and above that medial half is occupied by this canal. Okay. And it is about 3.4 to 4 centimeter in length. Okay. So the length if you are taking it is 3.5 to 4 centimeter. Then, about inguinal canal, to talk a diagrammatic view I will show you later. Okay, first we will finish off all these details, then after we will go for diagrammatic representation. Okay, so now talking about inguinal canal, we have two rings. Can you make out two rings here? So this canal, it is obliquely placed. One is present deeper. The opening which is present laterally will be present deeper and the opening which is present medially will be present superficially. Okay, so this canal we are seeing as inguinal canal, and this canal we can call these two rings, that is medial ring and the lateral ring, with other names such as superficial inguinal ring and deep inguinal ring. Also it is called as This is called as outlet of the inguinal canal and this is called as inlet of the inguinal canal. So this is considered as two ends of the inguinal canal. You can make out two ends, deep inguinal ring and superficial inguinal ring. So this is considered as deep inguinal ring and this is called as superficial inguinal ring. Then after we will be having some other boundaries, such as we will be having roof forming upper part of the inguinal canal, and then we will be having floor of it, and then it is also covered by anterior wall and behind we will be having posterior wall. So these are the boundaries we are going to deal. So altogether we will be having 6 boundaries which is going to form this inguinal canal. So about each boundary we are going to see detailing. So before going for the boundaries detail, we will just see how it is extended. As you know, we have 2 rings, right? Deep ring and superficial ring. Okay. So this deep ring, it is present, as the name itself indicates, it is present deeper. So we will be having deeper layer, that is in abdomen we have around 8 layers, right? In that 6th layer, after skin, superficial fascia, external oblique, internal oblique and transverse abdominis, we will be having a layer called fascia transversalis. So in the fascia transversalis, we have this opening. The deep inguinal ring, it is present as a oval shaped ring in the fascia transversalis. As it is present deeper, we are calling it as deep inguinal ring. Okay. Then we will be having superficial inguinal ring which is present superficially, that is in the 3rd layer. We have first muscle as external oblique aponeurosis, right? We will be having this part as aponeurosis. So in the external oblique aponeurosis, we have a triangular aperture which we are calling that as superficial inguinal ring. So that is the extent of the inguinal canal. From the fascia transversalis till the external oblique aponeurosis, we will be having extent of inguinal canal. Okay. Now we will go for each details such as boundaries. First we will deal with 2 openings such as deep ring and superficial ring. Talking about deep inguinal ring, as we already know, it is present in fascia transversalis. This green color shaded area, what they are showing us, fascia transversalis. So it is present in fascia transversalis and it is an oval opening and it measures above the inguinal ligament or mid-inguinal point. You know difference between mid-inguinal point and midpoint of inguinal ligament, right? Okay, so I will tell you again. We will be having inguinal ligament attachment from the anterior superior iliac spine till the pubic tubercle. So midpoint of inguinal ligament is midpoint between anterior superior iliac spine and pubic tubercle. If they are talking about mid-inguinal point, that is between anterior superior iliac spine and pubic symphysis. Okay, this is the difference. Midpoint of inguinal ligament between the pubic tubercle and anterior superior iliac spine. Mid-inguinal point between anterior superior iliac spine and pubic symphysis. Here, for measuring the deep ring, we are taking mid-inguinal point. Above the 1.25 cm above mid-inguinal point, we have this deep ring presence. Okay. Then, if you are searching for it again after dissecting, after removing the transverse abdominis, if you want to see the exact place of it, you have to search, one artery will be seen. So that artery we will call as inferior epigastric artery. So just lateral to inferior epigastric artery, you can make out the deep inguinal ring. So by this finding out this artery, it will be easy for us to identify the deep inguinal ring. Just present lateral to inferior epigastric artery. That's all about deep inguinal ring. Okay. It is also considered as inlet of inguinal canal. Yeah. Okay. Then we will go for superficial inguinal ring. As I said, it is present in the aponeurosis of external oblique abdominis. So this is aponeurosis of external oblique abdominis and it is a triangular aperture. So triangular shape you can make out here. So this triangular aperture, it is present 1 cm above and lateral to the pubic tubercle. Here you will be having pubic tubercle. Just above and lateral to pubic tubercle, you will be having this triangular aperture present in aponeurosis of external oblique. Okay. So this again will have some boundaries such as base of this is formed by, as it is a triangular aperture, base of it is formed by pubic crest. Pubic crest you know, right? Between the pubic tubercle and pubic symphysis you will be having a line. Okay, the line which you are seeing here, no, that we will call as pubic crest. Okay, so as this is triangular, we have apex and base, and this base is formed by pubic crest. Okay, then we will be having medial margin and lateral margin. This medial margin is this one which I am showing. Okay, medial margin, it is attached to the pubic symphysis. Lateral margin, it is attached to the pubic tubercle, and it is also considered as outlet of inguinal canal. Inlet is called as deep inguinal ring. Outlet of inguinal canal is called as superficial inguinal ring. That's it. Okay. Shall we move on to next boundary? So talking about other boundaries, such as we have two walls, anterior wall and posterior wall, and then we will be having roof and floor. As imagine like a room. Okay, room with anterior part, anterior wall, posterior wall, and above we will be having roof and below we will be having floor. Okay, as it is a tube. A tube like means we will be having only 4 boundaries. Understand? Okay. So anterior wall, it is again we are dividing into medial part and lateral part. Okay. On the medial part, again, if you are taking the whole extent of anterior wall, you will be having skin and superficial fascia along with aponeurosis of external oblique abdominis. Okay. On the whole extent, anterior wall is formed by first skin, which we will remove, then after superficial fascia, then we will be having aponeurosis of external oblique abdominis. Okay. Only in the lateral 1/3 we will be having some muscle fibers contributing for the formation of anterior wall. Those are nothing but fleshy inguinal fibers of internal oblique. So we will be having external oblique aponeurosis, and here this is forming whole extent. Okay. But in the lateral part of inguinal canal, some muscle fibers from internal oblique, it is going to contribute for the formation of anterior wall. So anterior wall, 4 structures are going to form. One is skin, superficial fascia and aponeurosis of external oblique. Only in the lateral 1/3 we have some fibers of internal oblique also contributing. Talking about the posterior wall of the inguinal canal, to see we can make out the whole extent of the posterior wall, it is contributed by fascia transversalis. So this is the part where we have fascia transversalis. So this fascia transversalis, it is going to contribute for whole of the extent of posterior wall of the inguinal canal. So this is the canal where it is placed. So now talking about the medial half part alone, it is contributed by conjoint tendon. So this conjoint tendon, it is formed by both the transverse abdominis and the internal oblique muscles aponeurotic fibers. Together it will join and form a tendon-like area that we will call as conjoint tendon. So medial half of posterior wall is contributed by conjoint tendon, and also medial 1/4. This part is contributed by reflected part of inguinal ligament. So we all know this is the inguinal ligament. So from the inguinal ligament we will get some reflected part which is carried out posteriorly to contribute for the posterior wall of inguinal canal only in the medial 1/4. So this is how posterior wall is placed for the inguinal canal. So now another topic. Along with this only we have to cover this. This is actually they will ask for 5 marks and all. Okay. Hasselbalch's triangle or inguinal triangle. Okay. This Hasselbalch's triangle, it is a triangular space which is seen posterior wall of inguinal canal. That is near to the fascia transversalis. We will be having this triangular area. Okay. This triangular area again have some boundaries. Can you make out medial boundary? A dotted lines you can make out, no? Okay, so we will be having medial boundary formed by lateral border of rectus abdominis muscle. You know this is rectus abdominis muscle. Again, the lateral border of this muscle going to contribute for medial boundary of Hasselbalch's triangle. Okay. And this is lateral boundary. It is contributed by inferior epigastric vessels. Not only artery, it is also contributed by vein. Okay, inferior epigastric vessels going to contribute for lateral boundary. Then we will be having base. This is base. Okay, base is formed by inguinal ligament. Okay, ligament. We will see this is medial border. Okay, medially this triangle is contributed by lateral border of rectus abdominis. Laterally it is contributed by inferior epigastric vessels, and base is contributed by inguinal ligament. So again, this triangle will be divided into two. Okay, one is medial part, another one is lateral part, by means of a ligament or fold. Embryologically, have you heard about medial umbilical fold and all? So that medial umbilical fold will be present between this Hasselbalch's triangle, which is going to divide this triangle into medial part and lateral part. Okay. So this is medial half and this is lateral half. This umbilical fold is not shown here properly. Just you imagine. We will be having an umbilical fold which we will call as medial umbilical fold, dividing this triangle into two parts, medial part and lateral part. Okay. Now we will go on to another boundary. So anterior wall, posterior wall we got over. Now we are going to see about floor. Okay. So talking about floor, it is very simple to remember. The floor of the inguinal canal is formed by inguinal ligament, because just above this inguinal ligament only we have this inguinal canal, right? So floor is contributed only by inguinal ligament actually, but sometimes it is also have some lacunar ligament, some fibers extending from the inguinal ligament to the pubic crest. Okay, so that is also giving a minor contribution for the floor of inguinal canal. Okay, so floor is mainly contributed by inguinal ligament along with lacunar ligament. Okay, if you are not writing like medial half, medial 1/4 and all also fine. Okay, just you write medial part contribution, that is by lacunar ligament, that is enough. Okay. Same in the case of anterior wall and posterior wall also. You don't want to remember exact details. Okay, you have to understand how it is oriented in our body. That much is enough. Okay. So now talking about roof. Okay, roof, it is again formed by arched fibers of conjoined fibers of internal oblique and transverse abdominis muscle. You know this, right? We already had seen conjoined fibers in posterior wall. Posterior wall, it is contributed by fascia transversalis along with conjoined fibers and reflected part. Here, that conjoined fibers is the major contribution for roof of the inguinal canal. Can you make out this is inguinal canal? Okay, this part we will call as conjoined tendon, which is forming roof over the inguinal canal. Can you make out? So roof is contributed by conjoined fibers of internal oblique and transverse abdominis muscle. So now talking about after boundaries, we have to deal about what are the structures passing through this inguinal canal. Okay, so those are called as contents. So this contents again it will vary in male and females. So in males it is mainly by spermatic cord and also ilioinguinal nerve. Okay. In male it is two contents only you have to remember. In male it is spermatic cord and ilioinguinal nerve. In female, instead of spermatic cord, we have round ligament of uterus. Can you make out the round ligament here? So round ligament of uterus is also going to pass along with ilioinguinal nerve. So there we have spermatic cord along with inguinal nerve, ilioinguinal nerve. Here we have round ligament along with ilioinguinal nerve. Ilioinguinal nerve is common for both the things, male and female. Okay. Only thing is spermatic cord is differing. In males it will be seen. Here round ligament will be seen. Clear? Okay. And one more thing you have to remember, we have these two contents, right? So in this round ligament and the spermatic cord, it will be seen on whole extent of the inguinal canal. It is the major content. Okay. But ilioinguinal nerve, it is a partial content because it is going to pierce the internal oblique and comes out in the middle of the inguinal canal. So it is considered as a partial content. Spermatic cord and round ligament is considered as a whole content. So about spermatic cord, just to remember, we have some structures passing through the spermatic cord. Okay, spermatic cord is going to carry all these structures such as ductus deferens, you know, right? It is vas deferens. Nothing but vas deferens. Okay, ductus deferens along with the three arteries such as testicular artery, artery to vas deferens and cremasteric artery. And then we will be having a vein called pampiniform plexus of veins. And then we will be having lymphatics which is going to drain testis and epididymis. And nerves such as genital branch of genitofemoral nerve and sympathetic plexus along the vessels. Okay, you can remember this easily. One thing is tube, that is ductus deferens. Okay, then after we have 3 arteries, 1 vein and 1 lymphatics, and again 2 nerves. That's all. Okay, one tube which is passing as ductus deferens. Okay, artery is testicular artery, artery to vas, and cremasteric artery. Vein is pampiniform plexus of veins. You can make out this arrangement, right? This pattern of vein arrangement. This we are calling as pampiniform plexus. Okay. Then we have lymphatics for testis and also for epididymis. And then we will be having nerves such as genital branch of genitofemoral nerve. Along with these vessels, whatever we dealt, okay, these vessels are covered by sympathetic plexus, so that also will be seen along with spermatic cord structures. Clear? So about coverings of spermatic cord, we will be having 3 coverings, from inner aspect to outer aspect. We will be having internal spermatic fascia. All these contents whatever we seen are covered by 3 layers. Okay. So that only we are calling as coverings of spermatic cord. One is innermost, we will call as internal spermatic fascia, which is derived from fascia transversalis. So from the deep ring we are having one fascia extending, that is fascia transversalis. Then we will be having second layer as cremasteric muscle fibers along with cremasteric fascia. This cremasteric muscle is nothing but the muscle fibers of internal oblique only. Okay, internal oblique muscle, it will get detached to form this cremasteric muscle. Okay, so second layer is formed by cremasteric muscle and its fascia derived from inguinal fibers of internal oblique muscle. Clear? And as we are talking, we have muscle here. Nerve supply you have to remember, that is nothing but genital branch of genitofemoral nerve. Okay. Okay, now we will remember like last outermost layer, that is external spermatic fascia. It is derived from external oblique muscle. Okay, these are the 3 coverings of spermatic cord: internal, middle and outer. Internal spermatic fascia formed from fascia transversalis, and middle layer formed by cremasteric muscle and its fascia, and the outer layer we will call as external spermatic fascia, which is obtained from external oblique muscle. Okay, now why this inguinal canal will be having defensive mechanism? Why this mechanism is needed? So we will be having this defensive mechanism for this because it is considered as a weak point, right? Because we have 2 openings here. So obviously we can get some contents protruding from the abdomen into this inguinal canal and come out. Okay. So to avoid that, we have some defensive mechanism. One we will call as flap valve mechanism. So this flap valve, it itself works as oblique canal. It is not a straight canal. So it is oblique. So by itself it will avoid passage of the contents from the abdomen. Okay, that we will consider as flap valve. Hello. Okay, and then we have deep ring in the fascia transversalis, right? So that deep ring, it is again strengthened by some muscle fibers which we will call as internal oblique muscle fibers. Okay, here you are seeing, right? This is deep ring. So here we will be having deep ring. Here we will be having some fibers of internal oblique going to contribute. So by that it will keep the ring in position. Okay, hold the ring in closed position. Then we have this shutter mechanism, you have to remember, very important. Okay, shutter mechanism, it is mainly by triple relationship of conjoint tendon. You know, conjoint tendon is formed by internal oblique and transverse abdominis. And this is for contributing in posterior wall formation, roof formation, and also some fibers are going to contribute in anterior wall also, right? Hello? In anterior wall we have seen internal oblique abdominis muscle fibers, and in the roof it is formed by conjoint tendon. Posterior wall also we have some fibers of conjoint tendon contributing. By the triple relation of this muscle and their tendon, it is going to give a shutter mechanism. So if any pressure is exerted from above, that is from roof, it is approximated to the floor. Okay, and also anterior wall, from posterior wall it will be closing, it will be approximated towards the anterior wall. If pressure is more, roof will be approximated towards the floor by closing the canal. Okay. And then anterior wall is also approximated towards the posterior wall by means of its conjoined tendon fibers, so that it can avoid the entry of contents, abdominal contents into the inguinal canal. Understood? Okay. So valve action is another mechanism. It is mainly caused by cremastric muscle. So this cremastric muscle, which is present in the second layer of the spermatic cord, it pulls the testes towards the superficial ring. Okay, the muscle which is present in the second layer, it pulls the testes towards the superficial ring and it acts as a ball-valve action. Clear? Okay. So talking about applied importance, we have this inguinal hernia. As you already know, inguinal hernia is nothing but abnormal protrusion of any abdominal contents which is covered by a fold of peritoneum while entering the inguinal canal. Okay. And it is divided into direct and indirect hernia. The contents, it may vary from momentum to intestine.